This is the video deposition of Bradford Lynn King, MD, in the matter of Christine Hommel versus Bradford Lynn King, MD, and Surgical Associates of Fredericksburg Limited, case number CO 14-349, in the Circuit Court for the City of Fredericksburg. This deposition is being held on February 11th, beginning at 2:50 p.m. The address is 4548 Empire Court, Fredericksburg, Virginia. My name is Bill Casamo. I'm the videographer representing Casamo Associates. Councilmen, introduce themselves and whom they represent.
Good afternoon. I'm Ben Glass. I represent Christine Hommel.
Robin Ayers on behalf of Dr. King and Surgical Associates of Fredericksburg.
Also present is the court reporter, Pat Stappa. Would you please swear in the witness?
Please raise your right hand. Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth under penalty of law?
I do.
The next sentence says 2 clips were placed proximately and 1 clip distally on the cystic artery. And
Correct.
so I'm clear, proximally refers to closer to the common bile duct.
Correct.
And the next sentence says the same clip was placed distally on the cystic duct. So tell me exactly what you were describing
Sure.
with those 2 sentences.
Sure. And the transcription here may not be absolutely accurate.
That's why I'm asking.
So I
yeah.
placed 2 clips here. I placed 1 clip here and I cut that structure. And once that structure is cut, if that is what I feel clearly identifies as a cystic artery, cutting that will help sometimes, not always. Sometimes it will help further pull this away. It will release that. That is one of the structures sort of binding this infundibulum, the gallbladder, to these structures here. So it will help further pull this away. And then I'll place 1 clip. It won't be the same clip I put on the arteries. It'll be a different clip right here on this part of the cystic duct, as close to the gallbladder as we can.
Okay, so to be really clear, you're not describing here placing 1 clip that encompasses both the cystic artery and the cystic duct.
Correct.
Correct, okay. What does the same clip then refer to? The same.
You might want to ask the transcriptionist that.
What do you think you dictated?
I probably dictated a similar clip. So whether I dictated similar, certainly did not intend to mean the same clip on the duct and the artery.
And it's not something you noticed when you signed it? And
correct.
do you know when you did that part, signed your name? And
Probably within 2.5, 3 weeks after the surgery.
do you know whether it was before or after you learned that she was in North Carolina with a problem?
I don't recall.
Okay. All right. So, so now you've shown me that you placed a similar clip distally on the cystic duct, and then you create the ductotomy. Correct?
Yes.
And that's what you dictated is what the transcriptionist actually wrote down.
Yes.
And the ductotomy is you're creating a hole through which you can now bring the cholangiogram catheter through so we can deliver a dye. through there.
Correct.
All right. So in this case, what did you do to assure yourself that you were creating the ductotomy in the cystic duct? Do you think that you actually cannulated the cystic duct for the cholangiogram?
That's what I believed at the time, yes.
Okay. Do you believe it now?
I'm going to object to the form of the question. I'm going to instruct the witness not to answer that question. He's not going to be an expert witness in this case.
Correct.
Well, just so that's the basis for your for your instructing him to not answer that question.
Well, I think it's irrelevant what his opinion is now. You're also asking him for an expert opinion. Okay. If we designate him as an expert, which we won't, but if we do, you're welcome to take his deposition again and ask that question.
Okay. At the time of surgery, it was your intention to cannulate, obviously, the cystic duct.
Yes.
Correct. All right. You bring the angiocath in and secure it with some sort of is that a temporary clip, the Liga clip?
It is. It's the same clips that we're using on the cystic artery and the proximal cystic duct,
Okay.
or distal cystic duct, I guess I should say there.
So is it an easily removable
Yes.
clip? Are the clips you had already placed on the cystic artery and the cystic duct easily removable? Well, you said it's the same clip, is it?
It is.
Really?
So the way the device works is as you apply the clip, you can see the far ends meet,
Yeah.
and then it starts to squeeze down. When I'm doing a cholangiogram, as I start to squeeze it down, I don't want to apply it 100%.
Okay. Just enough to keep
Just enough to keep dye from refluxing and leaking back out.
Okay. Fair enough. Let's talk about the cholangiogram process, first of all.
Yes.
All right. Are you running all of that machinery?
No.
Tell me.
So the x-ray machine itself is called a fluoroscopy C-arm, and we have a radiology technician running that machine
All right.
while I am injecting the dye.
And it's a live time image of what's going on as the dye is being
It is
injected.
a dynamic, live process.
Right. And we have one image from
Yes.
it. Did you only take one image?
We only saved one image.
Only saved one image. Did you? Well, how long is the dynamic process? How?
Typically 18, maybe 20 seconds.
Are you? I'll use the phrase taking picture. I mean, you got a video, a live video.
Correct.
And then somehow we get a picture out of it. Correct. Are you taking other images that you didn't save?
Correct. So the fluoroscopy machine, we don't normally set up to take a video and run a video of the images that we're taking. So at a point in time after I've injected and I've looked, and I will say stop, and they'll stop the fluoroscopy machine. I'll come back around and look at the images on the screen and tell them you can save that image.
Okay. And you did the part where you said you can save that image one time or more than one time in this case?
One time.
All right. And what does a cholangiogram give you in terms of information during the surgery that will either tell you something medically or help you do the surgery?
Well, what we're mainly looking for is obstruction distally in that common bile duct. I'm looking for a problem beyond where I'm going to take the gallbladder out, making sure that there's not a stone or some other obstructive process in the common bile duct.
Are you also looking at whether the biliary tree is intact
Yes, we're certainly trying to.
and has remained intact after some clips have been applied?
We're certainly trying to, yes.
At the time that you were running the cholangiogram here, had you divided any segments, arteries, ducts?
We divided the artery, but not the duct yet.
Okay. And is this image that we do have, in fact, let's go ahead and make this Dr. King Deposition Exhibit number 4. Is that image the image that you are describing in your operative note when you say that it's demonstrating normal intra and extrahepatic bile ducts and ready emptying to the duodenum with no filling defect?
Yes.
All right. Can you, and I have the original here. I suspect you've seen it because we lent it to you for
Yes.
a bit. And you're certainly welcome to look at the original. I just don't want to mark on the original during the deposition.
Sure.
But can you describe for us and show us with your pen, first of all, is the cystic artery visualized on the cholangiogram?
No.
All right. Should it be?
No.
Why not?
It's not-
I'm sorry.
It's not
My
in
mistake. My mistake.
continuity with the
You're right.
bile duct system.
You're right. the cystic duct, where we've cannulated and we're injecting dye, and I used the wrong word. Is the cystic duct seen on the cholangiogram?
On this cholangiogram?
Yeah.
I would even still look at this and have a difficult time telling you whether this portion right here is or is not cystic duct.
Okay, so let's mark what you've just said, this portion right here
Right there.
is or is not. So
Correct.
and let's draw a little line for a 1 there, just so we have a good record later. So as we look at that today, you have a question in your head,
Sure.
my words, about whether that small segment is a part of the cystic duct.
Correct.
Correct. All right. Is the common hepatic duct visualized at all?
And are you asking him when he viewed this back in 2000 and whatever year this was,
I'm at-
2012? Or
yeah.
are you asking him for his opinions now?
Yeah, well, I'm asking you, because you took this picture in the surgery,
Yes.
right? And at some point of the fluoroscopic procedure,
Right.
this is what
Right.
was seen,
Correct.
and you looked at it.
Correct.
Correct. So is the common hepatic duct visualized there?
Again, are you asking him his interpretation of it at the time that he saw it intraoperatively?
I'm sorry, I meant to make that really, really clear. Yes.
So
Okay.
at the time that I did this and the time I looked at this
Yeah.
on the image, on the day we did the surgery,
Yeah.
I still say, looking at this.
He's not asking for what
right,
you say
right,
today. He's
Right, no,
asking
I
for
understand. Looking
2012.
at this, back then, I interpreted this as reflux back into the common hepatic duct.
Okay, so that, again, we read a transcript later and we can all look at this. When you say you show me what, or draw somehow on this,
Okay. So if you see this right here, that's the tip of the actual cholangiogram cap. That's where dye starts to come out.
all right. Hey, let me stop. Billy, is there a way that you can zoom in on this thing at all so that we can,
While he's drawing on it, like,
or he moves up here or whatever, just so that we get a really
I can
good,
try
we all get a good record.
doing the up and then down and then.
Sure.
You mean walk it over here? Is that,
Do I want to walk? I
No.
don't even know if I need to. I think I can raise.
you're the guy.
Raise this up, tilt it down, and I might be able to see what we got. I can certainly see when he holds it up, but you want to see while he's got it down on the.
No, however works
Oh.
best so that we can all have a good record.
Oh, I can certainly get a great.
Okay.
Make it the whole screen with the video when he holds it up.
Can I have a quick peek? And if you'd like to have a peek, you may.
Do you want him to mark on it first, or?
Well, let's just, well, off the record for 1 second.
Can you hold it up again? I'm sorry. That's my maximum here. But that's gonna be a whole.
Pretty good.
That's, I mean, you're looking at it on a tiny screen too, so
Yeah, it's
when it's on a
pretty
big TV, I mean, it's gonna be pretty big.
I don't have to.
We can get you a big TV.
Okay, back on the record. What I'm trying to do is just to have as good a record as we can, so my experts, your experts, everyone can understand what you're pointing out here. So,
Sure.
the question is about the common hepatic duct.
Correct.
And whether it's visualized, whether you saw it back then at the time of the surgery, on this cholangiogram.
Correct.
So tell us what you believed at the time you saw.
Sure. Do you want me to keep holding it up here?
Yeah, can you do it that way?
If you can.
And I'll try to, I guess right there, that's where I see the tip of that cholangiogram catheter. As we inject dye tends to preferentially first go down, but we will sometimes and oftentimes look for dye to reflux back up towards the liver. Not all of us, in fact, most surgeons you speak with will tell you that they don't always look for, and in fact, rarely find the bifurcation up into the right and left hepatic duct. It's not a critical, but we like to see reflux back up into what we interpret as the common hepatic duct from here back this direction. So if this being the tip, at the time I did the surgery, I see dye going this direction, and I see dye starting to reflux back this direction.
That's isn't that called retrograde
Correct.
filling?
Retrograde
And-
filling,
And
correct.
doesn't the cholangiogram always retrograde fill up into the common hepatic and then the right and left hepatic ducts?
Not always.
Putting aside times when it may actually be obstructed by a clip or something,
Correct.
what would not make the cholangiogram dye retrograde fill into the common hepatic duct and the right and left hepatic duct?
Gravity.
How does gravity
So a patient's on
Prevent
the
that.
operative table. To do this operation, we typically will take them and tilt them upwards.
Mhm.
Everything's going downstream. It's not uncommon. In fact, myself, many surgeons I know, many times during residency, we had to actually flatten the table out and put the table head down if we really wanted to see that bifurcation into the right and left hepatic duct.
Okay.
So your question being, do you always see that? The answer is no.
And if my question was, in what percentage of time do you then not see it? Can you give me a number there?
I'm going to object to the form.
No.
You can answer.
Okay.
No.
Is the pancreatic duct visualized on the cholangiogram?
Yes.
And you understand all of these questions are what you saw at the time.
Yes. Pancreatic duct, I believe, I'm looking at it from behind this, but it goes this direction here.
Right. So does that mean that the dye fluid has gone down
Yes.
and now is going back up?
Well, it's a dynamic process.
Mhm.
As it goes down, we may also see it start to go up, back up. And it may be starting to go back up as it's going down. A lot of it kind of depends on what's going on right down here where the bile duct empties into the duodenum.
Mhm.
There's a sphincter there, and if that sphincter's wide open and there's really no resistance to passage, a lot of your dye will simply flow directly into this duodenum.
I got it. But I'm talking about the pancreatic duct and whether now dye is flowing against gravity, really, on
Well-
this cholangiogram.
Well, again, that pancreas is going to be more like this right here. This would be your pancreatic duct here. So even if you have the patient tilted up, it's not really going to have to flow back upstream the way it has to go in the hepatic duct. It more goes in a tangential fashion this way.
Okay. Do you, am I correct in saying that you did look at this image because you said, hey, stop the cholangiogram, take this picture and save this?
Yes.
So you looked at this during the surgery.
Yes.
Did it concern you at all that you could not visualize the common hepatic duct or the right and left hepatic ducts?
Well, I believed I saw the common hepatic duct. Did it concern me at the time I did not see the right and left hepatic ducts?
Yes, sir.
No.
All right, and again, where do you see the common hepatic duct?
Well, at the time I interpreted this coming back this direction to be reflux back up into the common hepatic duct.
Okay, and would you let's see, could I just look at this for a second? Let's draw a line to the dot I think you marked here, which is the insertion of the cholangiogram catheter.
Tip of the cholangiogram.
Tip of the cholangiogram. It's not actually the insertion, that's the wrong word. It's
Correct.
It's where the catheter ends up, where the dye is coming
Where the
out
dye's
of the...
gonna first come out of.
Exactly. That, you've marked a dot. Let's make that really clear.
Okay. So I've drawn an arrow to it
Thank you.
and made the dot a little bit bigger.
All right, and if I was to say north of the dot, where the image is darker, is what you at the time felt was the common hepatic duct.
Correct.
All right. Can you visualize clips?
Yes.
Can you show us clips?
So, clip. Now, these structures here don't have the typical appearance nor the size of our clips.
I'm going to have you can explain that to me, and then we'll
Sure.
do it in front of the TV here in a second.
So, this I would say is a clip.
All right.
This I would say is a clip. This darker shadow and this darker shadow, I would not interpret those as clips.
Okay, so
I wouldn't expect those to be there. The only clips I would expect to be in the field at that time are clips that I placed on the cystic artery, and then the single clip on the cystic duct where I inserted this here. We might have one more clip. Perhaps this one is a clip based on, we should still have we should have 3 cystic artery clips still in the picture, and at least one cystic duct clip in the picture, and another clip here where this goes here. So I would interpret these as those clips.
Okay, so let's do as best we can again, so your experts and mine can both look at this. Draw a box around the northernmost clip, I guess, and tell us what structure that clip is on.
And again, he's asking for your interpretation in 2012.
Yes.
Not today.
And at the time of the surgery, I would interpret that clip to be one on the cystic artery.
Okay. There's then sort of below it, and I would say angled from upper left to lower right. Is that a clip?
Yes.
All right, why don't you draw a little box around that clip? And
Sure.
that clip is on what structure?
That clip, I believe, is the second clip on the cystic artery as well.
All righty. Then where does the third clip that you can
So there's a dark
see?
shadow here, and then there's also a small shadow here. I'm not sure if that represents the clip on the cystic duct above. Probably does.
Okay.
And it's just at a funny angle, so you're not seeing the full.
Right, you're not
length of the
seeing
clip.
it
Exactly.
straight on, right.
I would suggest this is the clip on the cystic duct
Okay.
above where I made my ductotomy. My cleregium catheter then feeds in and goes down, and there should be one more, and you're probably not seeing it all because of the dye and other things, but there should be one more clip in essence in this area right here.
Okay. So let's just put a little square around the what you believe to be the clip on the cystic duct. And again, is that the distal clip or the proximal?
That would be
Clip.
the distal clip if we're talking proximal distal on the cystic duct.
Okay. At the time of the surgery, why did you pick this time to ask the radiologist to stop and take a picture of this point of the cholangiogram?
I believed I'd seen everything I needed to see.
Okay. And would I be correct in saying that throughout the 15 or 20 seconds or whatever it was of the cholangiogram video, that you didn't see anything that was significantly different than what we see in the image that we saved? Is that right?
I'm going to object to the form of the question, and I also think the word video mischaracterizes.
I don't mean to mischaracterize it, because a video would mean like a recording, and I understand you say there's no recording of the whole thing.
Correct.
However, there's a moving picture on a screen,
Correct.
and at one point you say, stop, take a picture of that.
Correct.
And my question is, as you watch the moving picture on the screen, is this representative of what those other 15 to 20 seconds was?
Yes.
Okay. Going back now to the ALP note, the cholangiogram was obtained in standard fashion, demonstrating normal intra and extrahepatic bile ducts. What is an intrahepatic bile duct?
So that would be those left and right bile ducts.
Before they join.
Correct.
All right. And can you show us on the cholangiogram where you see?
No.
Okay. So does this cholangiogram demonstrate a normal intrahepatic bile duct?
And again, you're asking him his opinions at the time.
Yeah.
This static image
Yes.
does not.
Okay. Did you see anything else in the moving image that demonstrated a normal intrahepatic bile duct?
I don't specifically recall,
Okay.
but there's certainly plenty of times when we've seen dye flow up, and by the time we take the static image, it's come back down into that common hepatic duct.
All right. But you don't have a specific recollection?
I do not have a recollection of specifically seeing right and left hepatic ducts
All
at
right.
the time.
And I think you dictated this, it looks like 7 minutes after the surgery was over.
Correct.
All right. And let's just talk for a moment about the extrahepatic bile duct. That refers to what?
The common hepatic and common bile duct.
Okay. And I think you have shown me already what you perceived at the time to be the common hepatic duct.
Correct.
Correct. And the common bile duct is pretty clearly seen.
Yes.
Let's just say south of the cholangiogram catheter point.
Correct.
Right. All right. I just don't remember what you told me a minute ago, but does this image show the 2 clips of the proximal cystic duct?
Yes, I believe it does.
Okay. The op-ed says we removed the cholangio catheter and placed 2 clips in the proximal cystic duct and transected this.
Correct.
So to me, that would say that that was done after the cholangiogram was done. Am I misreading that?
No, that's correct. Those 2 clips were done after the cholangiogram was completed.
And they're visualized on the cholangiogram.
No.
Okay, I'm sorry, I misunderstood what you
Right.
told me just
So
3 minutes ago.
after the cholangiogram is completed and we freeze that image,
Mhm.
we then remove that cholangiogram catheter.
Right.
We place 2 clips proximal to the ductotomy and then transect typically right at where we made the ductotomy.
And then you go on, the gallbladder was dissected free and then essentially typically removed.
Correct.
You had no difficulty at that point.
Correct.
And when the surgery was over, it was your impression that this had gone like your other 1,000
Correct.
laparoscopic cholecystectomies.
Correct.
All right.